Hello. Thank you so much for coming. I'm Tracy Green, and I am coming to you from the COBRE on opioids and overdose at Rhode Island Hospital. I'm happy to be hosting and as co-director of the center, and also the Transformation and Translational Core hosts these hackathons. This is our second hackathon. Thank you so much for coming. I'm Tracy Green. Uh-oh, I'm going to keep talking through myself. We're excited to have this second event that's both in person and virtual as a grand experiment. This great challenge of our time of overdose, and we are experiencing within a pandemic, is a challenge that deserves both much more than a hackathon, much more than a weekend. And the researchers and volunteers and community organizations and leaders that you're going to meet and hear from and tonight, I hope will inspire ideas for hacks, short, small ideas, or big, longer term investments in your time and energy to help change the course of the epidemic and improve the lives of people who use drugs. One small notice that we are hosting this virtually online on AirMeet, which is the platform that you all have registered on. You probably have, in the registration process, created a profile. So just a small thing to encourage you to look around on the website and visit your profile in particular, because as we join together and make teams, it will be fun and important to meet one another and make new friends and find new collaborators. And the best way to do that in a virtual space is to do so with keywords that help introduce and ground who you are and what you're doing. Friends and collaborators in a virtual space or in a socially distanced way. So I think this virtual hackathon gives us a lot of choices and hopefully will inspire even more change and excitement. And if you are one who gets inspired at 2 in the morning, feel free to use that app at 2 in the morning. I will admit to doing that sometimes too. But in the meantime, please enjoy the next couple panels where we'll hear a little bit about the challenge of the epidemic right now, and then also hear about some inspirations in hacks, new innovations that have come about from amazing thought leaders, and a keynote speaker who will, I think, inspire us all to think more about harm reduction and harm reduction innovations. And then finally, also hear about past hackathon winners and some thoughts about how to get across the finish line and create new and exciting hacks that might just win. Thanks so much. And please welcome Brandon Marshall, my colleague and friend.
Thanks, Tracy. It's so nice to see everyone in person. This is a delight. I'm going to be introducing our keynote speaker in a moment, but I wanted to say a few remarks this afternoon to kick us off, and to throw out a number for you, which is 384. That is the number of Rhode Islanders that died of a drug overdose last year. It's more than one every single day in our small state. Across the country, more than 250 people die of a preventable drug overdose each and every day. And we gather here and engage in this work because we know that these tragedies are preventable, right? That overdose death is preventable and that there are solutions. And that's what we're focused on this weekend. Yet we've been dealing with this crisis for many years now, and there is seemingly no end in sight. The COVID pandemic, as Tracy mentioned, has exacerbated the overdose epidemic and taken mortality rates to unprecedented and unacceptable heights. And now with an unregulated drug supply becoming more contaminated with fentanyl and affecting more substances, an extraordinary number of people are at risk. So there is a lot of understandable fear out there in the world right now. And the problem with fear is that that can lead sometimes to steer our drug policy in a negative direction. It can lead to criminalization, to stigma, and only entrench and reinforce racist policies and racial inequities. We face additional challenges brought on by the pandemic, which we've all gone through: isolation, increases in stress, an affordable housing crisis here in Rhode Island, unemployment, and a shortage of injectable naloxone. So now more than ever, we need new ideas and approaches, and that's where an event like the Hackathon comes in. Innovative and novel ways to address overdose and move us away from these fear-based approaches and towards hope, which is the motto of our small state. So as much as things are bad right now, we also have much to celebrate. And I do think this is a unique time in American drug policy where we're making good progress. And Rhode Island is a national leader on this front. We are the first jurisdiction to implement a statewide system for medications for opioid use disorder in our correctional system. We're one of the first states to legalize the distribution and use of fentanyl test strips and other drug checking equipment. And we are the first state to authorize a harm reduction center, what's known as supervised consumption sites. So we are leading the nation, and there is a real opportunity here now for us to move American drug policy into the future, a future focused on health, on reducing harm and care and compassion. And your work, our work at the Hackathon can be part of this momentum. The Hackathon, I love this concept. It's kind of radical because it democratizes the process of finding solutions. Anyone can participate and crucially are encouraged to work together to find solutions to a problem. And it allows us to look at problems differently by engaging people from different backgrounds and perspectives who hold different viewpoints than we do. And this is important because the overdose crisis affects every corner of America. So we need solutions from many different stakeholders. But it must involve people who use drugs. It must involve people with lived experience and others who are directly affected. So the solutions here today, my hope is that they should not be limited to the ivory tower or the halls of state houses or congressional buildings. They're really going to come from the ground up this weekend. So the hackathon will last a few days, as Tracy mentioned, but I hope your enthusiasm and passion for addressing this crisis will continue well beyond, whether you live in Rhode Island or are from another state. We have people joining this weekend from across the country. If this is your first foray into drug policy and overdose solutions, there's plenty of harm reduction coalitions, government boards and commissions, and drug policy organizations that need your participation and support. There is legislation to lobby for, to testify for, and to protest for. And there are people in our state and across the US who need housing, who need resources, who need naloxone, and who need other supplies and care. And there are millions of people affected by the overdose crisis and that need that compassion and support. So that's our goal this weekend. And as a judge on Sunday, I'm looking forward to seeing some of the incredible solutions and innovative approaches to tackle what is an incredibly complex and unprecedented problem. So to help frame our thinking around this and to talk about some national efforts, it's my pleasure now to introduce Dr. Kim Soo. She is a medical director of the National Harm Reduction Coalition, where she provides national training and technical assistance to improve the health and well-being of people who use drugs. She's a practicing board-certified addiction medicine internist, anthropologist, and instructor in the program in addiction medicine at the Yale School of Medicine. She's a graduate of the Harvard Medical School's Social Science MD PhD program, which is where I met her, and completed her medical training at Massachusetts General Hospital. She's published a book, which I recommend you pick up and read, called Getting Wrecked: Women, Incarceration, and the American Opioid Crisis, which uses a medical anthropology lens to examine the intersection of the US prison system, addiction policy, mental health, and treatment involving women in Massachusetts. And she has worked in diverse clinical environments, including syringe service programs, methadone clinics, the Rikers Island jail prison system in New York City, and in response to the COVID pandemic as well. And I am very honored to consider her one of my colleagues and friends. So with that, I'd like to welcome you all and bring up Dr. Kim Soo to give the keynote this afternoon. Thanks so much.
Thank you all so much. And thanks for inviting me and having me. And thanks for that kind introduction, Brandon. So I actually was reflecting on with Tracy actually and Michelle about how I participated in a hackathon in a district hall in Boston, maybe 4 or 5 years ago. And I was part of 2 teams, SIF on a boat, which modeled itself after Ireland doing abortions on a boat to create a safe space on the ocean. So that was an interesting kind of policy hack. And another one called Matmobile, which basically was mobile buprenorphine, which really does happen now and is not that novel an idea, but at the time we were like, that's a great idea. Like you could just do Matmobile, so MOUD on a van. So that actually was the coalescence of what became this advocacy group in Massachusetts called Stigma now, which I met Aubrey Esters, who was like a fierce advocate, who I would like to like donate a lot of my talk to in her memory. But she really pushed me as a clinician, as a friend, and I just met wonderful people, and those relationships lasted for years. So I hope this happens for you as well. So I called this, What Can We Do? And I think Tracy and Brandon have outlined, and hopefully I'll kind of help you think through some of how I think about what we can do for people who use drugs at this moment. And so excited that you're joining us from around the country. So a little bit about National Harm Reduction Coalition is we are a national organization. We sponsor a big conference every 2 years that sadly was delayed by COVID last year, and it was meant to be in Puerto Rico. We provide policy training, technical assistance, and a lot of resources that you might have encountered on our website. I have no disclosures. These statistics are grim, and Brandon presented some of the ones locally here in Rhode Island, but the national statistics are also grim. And we're basically in this steady climb, this unending steady climb. And it's not only opioids, while this is an opioid hackathon, polysubstance use, many other substances as well are really also causing increases in death. This is data from the CDC, Overdose Data to Action, that shows in the last year really states where drug overdoses and emergency department visits were going up. So there's a lot of regional and statewide changes as well that are important to note. Another thing that's really critical, and this has been going on for a long time, so this is not anything necessarily new, but racial and ethnic disparities in overdose deaths. So this has been really disproportionately affecting Blacks and Hispanics, and that these numbers continue. So I'm hoping that there's ways that we can think about incorporating these ways that we can hack some of these persistent and longstanding inequalities in health justice. I have some slides also about methamphetamines and cocaine, because even in the absence of opioids, we are seeing increases in deaths. And I think for many people, including people who use stimulants, this is also sort of a health justice issue. And I want us to not be so opioid centric. While we know that opioids are a primary driver, to pay attention to people who use stimulants, including people that smoke stimulants. So cocaine as well. And I'll do a little grounding for what is harm reduction if this is the first time that you're learning about it. And at National Harm Reduction Coalition, we've kind of defined it in a broad, sweeping philosophical term, and also a practical sort of set of strategies. And when I talk to doctors or clinicians, we often talk about the sort of practical strategies. But when we talk to people in the movement, we really want to say, like, this is a movement, and we really want to shift power and resources to people vulnerable to structural violence. Like, we really want to involve people who use drugs. We really want to not focus only on naloxone. And we don't really just want to focus on syringes, but we really want to liberate people to, we want to equip people with their basic needs. And we want people to be able to flourish and not only survive, but flourish and thrive. So that's part of that broad sweeping movement. And then when I'm talking to interns at the hospital, we talk about, okay, making sure, like, how do you prescribe syringes? How do you actually get people what they need if you're in the moment where you can actually help them? So those definitions, I'll put those there for you. And it's a common misconception for many people when I'm talking about what harm reduction is and the services that we have in the little h, little r category, to really think like, oh, it's syringes, or oh, it's naloxone. And we really think broadly about harm reduction as a wide variety of services, including drug checking, housing first. You guys are paving the path for overdose prevention centers, and even pharmacy access, which is just so critical. If you have a pharmacist who has a standing order for naloxone, or who can sell you syringes. Some pharmacists are working on fentanyl test strip training. I mean, really pharmacists can hold the key to the kingdom. So really thinking about harm reduction across a variety of spaces, and thinking about service harm reduction as all of these different components. Even low barrier medication, where people don't cut you off if you've used intermittently and you only take your medication a couple of times a week, like that I would consider a harm reduction approach. So principles of harm reduction, I won't necessarily read them off for you, but they often get waylaid, and they're very pragmatic, and they put people who use drugs first. They promote health and dignity, and they're just very pragmatic and realistic. Like, what do you need? How can I help keep you safe, healthy, happy, thriving? And how can you be involved in that process? So one of the models that we use is risk set setting, and you might have heard it as drug set setting. And I thought this might be useful to think about as a theoretical framework for you to think about hacking any of these domains. So for example, the risk might be injection drug use, sex work, whatever we're discussing. The mindset is the set part is the attitude, the expectations that people have, how they're feeling. And the setting is this physical and social environment in which people can use. And, setting, for example, the most obvious example might be, you're in a Dunkin' Donuts bathroom, or you're in a Rhode Island harm reduction center, right? You're in a place that is, you don't have time, you're rushing, you're in opioid withdrawal, you're locked, people are knocking on the door, or you're in a place where you have access to supplies to clean your skin, to take your time, to find a vein if you need a vein finder, or if you need warm water to bring up a vein, right? I mean, the setting, thinking about decreasing your risk for infection, for abscess, if we can intervene on any of these particular things to make any of this safer, I think that would be really, really wonderful. You're thinking about the risk setting, so drug checking might fall into the category of the risk setting. So people actually know with a mass spectrometer what they're actually using, like that is knowledge, that's empowerment, and that ultimately I think leads to safety. So, the past year, we've seen sort of attacks and losses in the harm reduction field around the country. This is Oasis in Atlantic City. This is Austin, Indiana, and this is West Virginia. So I think it's also really important as we think about policy hacks or thinking about why are we losing ground? Why in places where there were literally Indiana, Scott County, Indiana was the birth of, HCV and HIV clusters and epidemics that, were in fear of recreating, and that is becoming eroded. So what is going on in our political environment today, in our socio-political environment today, in our communities that are often based on politics of fear, I would posit, that are eroding these evidence-based services. And the New Jersey testimony, for example, it didn't really, 200 people testified in favor of the syringe service program. And the board, still evicted them, or you know what I mean? And so it's like, we believe in evidence, but do people believe in how do we change hearts and minds, right? And so as people who care about data, as people who care about evidence, how do we also talk about hearts and minds and affect and emotion and feeling, and how do we recognize that leads to policy, and so I don't have the answers, but I have kind of watched, sort of syringe service programs struggle and or go underground as a result of some of these policies. I'd also like to talk about hacking stigma. So if we can think about ways that we can address some of the really harmful ways that stigma works, both at a internal level, at a community level, at a larger cultural discourse level. As an anthropologist, I think there's a lot of work that we can do in this area. So this is an example of New York City, where I lived for several years. And during COVID, says the ugly side of New York's outdoor dining renaissance. During COVID, there was a lot of displacement of people. There was a particular hotel that became the sort of vanguard of some neighbors' ire. It's called the Lucerne Hotel in the Upper West Side, and there was a group that basically was like, we do not want people who are homeless, who are being housed in COVID hotels, to be in our neighborhood. We don't want to have to watch our kids go into Walgreens and have our kids, see our kids, have our kids see someone being revived with naloxone. We don't want people, ruining the landscape of our neighborhood. I was called into a group that formed in response called Love and Safety, that was trying to welcome the people who moved to the Lucerne, who really felt happy in that in their hotel, and they really felt housed and happy for the first time, and they were able to access their healthcare services from there. And so, but this was very controversial. Also known sometimes as, the associated with stigma is the term NIMBYism, or not in my backyard. And that's a really important thing whether we're thinking about methadone clinics, whether we're thinking about zoning, whether we're thinking about harm reduction centers, we're thinking about what do neighborhoods want and need, what do the most structurally vulnerable need and want. And this was a campaign that we had at Harm Reduction Coalition and the San Francisco Department of Public Health. And it was a campaign that was revolutionary, or very simple in some ways, where it featured people who use drugs, not necessarily people in recovery. It featured real people. It featured people taking care. It showed people taking care of each other. And it was with a lot of harm reduction strategies and techniques that for you all, like going slow and testing the drugs, like making sure you're using with someone else or carrying naloxone, knowing how to use it. And this campaign was actually quite controversial, and city alders and things, there was a lot of vitriol. There was particular attacks on some of the images of people who were Black, Indigenous people of color who were featured in it, where Black African Americans were like, I don't want to see like a picture of a Black man, telling me to use a harm reduction strategy. And I find that offensive. And there were other images, which I don't have here, but there were images of people in like LGBTQ, trans people who were partying, people who were like, test your drugs. And those were very offensive to many people in the community. They were like, this condones drug use, like you're making it look cool. You're making it look like seductive, like fun. And it really was very, the responses were actually very telling and very interesting. And I think that as a phenomenon, these are things that, so the campaign ultimately was taken down. Many billboards were taken down, and even in like kind of a city that we think is very politically liberal, like San Francisco, it wasn't very quote unquote successful. So we know that during COVID, things have only gotten worse. At the beginning of COVID, we put out resources, and I was scrambling at the time where I was like, this is going to be terrible. This is going to be terrible for people who use drugs. Like I was expecting like a cliff, and so many of the deaths, that, I think the CDC just revised the numbers to 97,000. So like this was really bad. The stress, the isolation, the trauma, the access, the boredom. I mean, all of those things led to increased use. At the hospital, we're seeing many more people in acute liver failure. We're seeing way more alcohol use disorder, people who otherwise would have been employed and have sort of a structure, really sort of having catastrophic consequences in their lives. And so we put out a variety of resources. And so thinking about COVID being like the new normal, and we had a world that was pre-COVID, and we're moving into like a COVID, a life with COVID, where it's going to be endemic. Like we really need to think about how you guys can hack, how we all can think about this new reality and grapple with some of the changes that are probably going to be permanent. I remember people asking me, I'm homeless, and I'm showering in a bathroom. So if I use that like hand blower to dry off my hands, will that spread COVID? If I'm doing this sex work thing, will that spread COVID? I had no idea. We all had no idea, right? I was just not guessing, but like doing the best I could. It was really common. I was just trying to use common sense. We really didn't know how COVID was transmitted. This was in March of 2020. So I love this slide. This is a slide from New York State Department of Health, and we're always like, how did we even like get this through our like state health department? Because it's secretly really cool. For things that state health departments do. And so if you think about all of these different domains, finding a buddy or seeking help during a mental health crisis, finding a safe space, checking your drugs, managing your use, polysubstance use, using multiple drugs at once, like all of these domains are places where you can imagine there being certain hacks. How do people even find like a syringe service program? Like how do people even know where one is? So there's a lot of things, safety planning. And I really like this scheme that Tommy Brothers and his co-authors used in a recent paper on injection and injection-related infections. And I like this scheme just because it takes the emphasis not necessarily on the individual behavior, which as clinicians, we often focus a lot on, which is like, okay, well, did you like use an alcohol pad before you did an injection? And, did you use, but we really going into these like micro environmental and macro environmental factors that have huge force, have a huge pull on if you're able to use an alcohol pad, if you're able to access naloxone, if you were able to access buprenorphine or methadone. And so I think I wanted you to think about these schema and to be ambitious in the hackathon and think about, okay, housing. So what would I do? How would I like create a one-stop shop that has housing, healthcare, everything that people could possibly want to need in a one, a one facility, for example, or like what, the criminalization of drug use. So I get called about states where fentanyl test strips are not legal. And they're like, so how could I hack that? Or, how could I get people, safe supply or things like that. So it takes the focus away from individual behavior per se, and I want you to think more broadly. Certainly individual behavior is an important factor, but also what else can we do on the outside? And again, this schema for skin and soft tissue bacterial fungal infections, and thinking about, things like previous negative healthcare experiences. Many times I talk to clinicians and I say, okay, so I want to improve the care for people that come into the methadone clinic. How do they feel like accepted, loved? How do I take care of their diabetes? All these other things. But if I actually worry about people who I get phone calls from people in Oklahoma who I say, I have an abscess on my breast, I'm injecting, I have kids, I would rather die than go into a hospital because my child will be taken away from me. What should I do? I get those calls. And so how do we hack those systems that are like of structural racism, surveillance, social control? Like I worry about people that would rather die and do die because they don't want to interact with me. They don't want to come to me. They don't want to come to us because of things that have imprinted on them. So how do we hack those? How do we prevent those things from happening? Policies and laws governing pregnancy and drug use, for example, is, so mothers, what do I do for mothers, people, parents who are using chaotically? And, racism is a really important lens as well, so there's when we do harm reduction training for community health workers or other people, community-based organizations, there's an article that we use which says, carrying naloxone while Black. And it's like, I will not carry that in Philly because I already am criminalized for being Black. And I do not want to have anything that looks like drug, quote unquote, paraphernalia on me, even if I could save my friend's life and I understand what it's for, I will not carry it, and so how do we think about, how do we grapple with sort of the structural racism, segregation, systems of surveillance and social control? So what keeps me up at night? And these are a lot of questions. These are a lot of things. And I'm not sure, hopefully you guys will think of some of the solutions. Okay, this is page one of 2. How can we prevent non-fatal or fatal overdoses? And the reason I say this, non-fatal too, is because non-fatal overdoses are scary. They are scary, they are traumatic. There are, groups of people who reverse overdoses because it's so traumatic. And there is significant, confusion. There's anger. There's all kinds of feelings that people have when they're involved in reversing an overdose. And it can be confusing and scary for people who survive them as well. How can we prevent infections? How can we address healing and these problems of grief, trauma, unending overdoses for people who use drugs? The basic problem of social isolation, which seems to be getting worse in COVID, building connection and safety. Meeting basic human needs is something that we, it seems obvious to say, but people still don't have housing. People still don't have food. People still don't have what they need to take care of, pay for a phone, for example. And how how can we ensure people are using safe substances alone or in combination? We know that polysubstance use is the norm. People are not, just using one substance. And so I think trying to understand that and trying to think about, okay, people are definitely using multiple substances. How do we keep people safe and make sure that they're having safe and copacetic kind of experiences that they want? I feel like the psychedelic community is very interested in, like, we could learn from the psychedelic community. They're very interested in like creating like a good experience, and like how do we understand that people are using drugs to have good experiences? How do we address structural racism and harm reduction in treatment centers? How do we increase access to life-saving medications? So these medications that we have, they're locked up. There's waiting lists. It's still, people are still kicked off of methadone and buprenorphine. People, still have to wait 2 weeks. People have to pay cash for so there's so many different ways that these medications that are highly effective are locked up and kept away from people who need them. Intervening on stigma and shame, intervening on the carceral footprint of police, jail, family regulation systems, child protective services, supporting and engaging people who use drugs in advocacy, centralizing their voices, and supporting people who use drugs and people who engage in sex work and achieving their goals. So that's some of what I am worried about. Other questions I have. How can we hack these outdated buprenorphine and methadone regulations and expand access now? Low dose initiation, freeing methadone from the clinic, liberating it to a pharmacy, or liberating it to other kinds of primary care models. How to increase access to naloxone for people who are currently in this naloxone shortage. Thinking about a safe supply. Really, I do feel like when I tell my patients to go out and use like a fentanyl test strip or to use naloxone, that I'm relegating them to play Russian roulette. Like, I literally am asking them to go out and play Russian roulette, and that is unacceptable. Like, it's terrifying for me and for them. And so I really feel like safe supply is where we need to be. I would love to be headed there. How can people afford and access harm reduction equipment and supplies, particular concerns of youth and aging people? There are a lot of aging people who are using drugs. There are a lot of people in their 60s and 70s that are using drugs. And so I think it's a unique population. I think it's a growing population, and there are certainly have medical frailty and increased risk for morbidity and mortality already. And so I'm definitely worried about them. Keeping our LGBT, transgender, non-conforming folks safe and thriving, and how to create sociocultural systems and discourses that allow for people who use drugs to acknowledge that people use drugs for pleasure, exploration, and growth. So I actually read a member of Drug Policy Alliance wrote she got sick with COVID, but she wrote an article at the time of COVID that was like, we really have a discourse for white people that's completely different from Black people. And like, white people are allowed to consume cannabis in their dispensaries, and they have all of their Peloton for wine and like cannabis curated, mommy groups. And for Black mothers, it's like they do not feel safe. They do not feel supported. They're surveilled. Their children are taken away. They're put on the federal registry if cases are called on them. In New York State, for example, the federal registry or the state registry, state central registry, if someone charges you or calls the state about a concern of neglect or abuse on you, and that charge is investigated, your name exists on the registry every time you're applying for a job and housing until your oldest child is like 28 or 25. Like, that is a hugely structurally racist system that, people wrote articles that were like, stop the registry, because this is literally like a very structurally racist system. And then treating pain, for people with and without SUD. And pain is obviously a topic of considerable interest, but, from my point of view, really, how do we comprehensively treat pain, whether it's with opioids or not, for people who need it? And I think that mentioning pain is really important because it does overlap in many ways with what we do. And, I'll just say that, I put some images of people that we've lost in the last year. Michael K. Williams, who is an actor, a very acclaimed actor that many people knew from The Wire, from Omar Little. He died of an accidental, it's always called accidental, but he died of an opioid and cocaine, fentanyl overdose. Jason Crowell, who was a harm reduction worker in New Haven at Sex Workers and Allies Network. He died about a month ago of an opioid overdose, and he was working very hard on getting an overdose prevention center in the area, and that was his kind of life's work and passion. And I was also talking to people who were like, in the harm reduction community, we didn't even know people were using, and like, we are the people who want to like, please tell us, you know what I mean? And so like, what is the process where we keep losing our own people? That's like a particular problem that keeps me up at night, which is like, we should have the tools, the safe space, the connection, the community to support our own people who are using. So what does it mean for us to keep losing our own people? And Dylan Stanley, who, this is a picture from St. Louis where Jody and I last met, but she died of an overdose. And she really spoke very publicly. She was a harm reduction worker in Ohio. And she spoke very eloquently about the way that Child Protective Services really made her life like a living hell, basically. And she was cycled kind of in and out of different kinds of treatment programs. She was really distraught by sort of the way that the systems treated her, including the CPS system, but also just the treatment systems. And she really struggled. And ultimately, I think after this picture, she died maybe 6 months later. So this is, I end on this note because like, these are our friends, our patients, our neighbors. Like, these are wonderful people. And the tragedy of it is that we have the resources, we have the intelligence, we got vaccines for COVID in like less than a year. Like, how did that happen? And yet we still can't really hack these problems where people that are so brilliant and have so much to contribute to our society are really subject to premature death, and these are, I think, where I hope that we can hack that this weekend. So I'll end with that, and thank you for all your work today and this weekend.
Thank you. Actually, could you stay there? That would be wonderful. With our setup is that I have a microphone if people have questions for Kim who are here. And we do have some questions from people on the live feed and Q&A. So I'm just actually going to read those.
Great.
And Brandon, I don't know if you want.
Articles published on the fact that people who use drugs feel like our healthcare systems feel like jail. They feel like they are that the slide where I showed you autonomy, and people have no autonomy. So people feel like it's jail and prison. I was taking care of a patient who was hospitalized for 6 weeks of antibiotics for endocarditis, and she left many times because she just was subject to a lot of surveillance. Her visitors were restricted. She had a PIC line, which meant, and they were like, okay, well, with her PIC line, if she leaves, we can't let her have her regular clothes. We have to put her in like a yellow gown to flag that she has a PIC line. So it was almost like they were creating this exceptional costume for her to wear that like they didn't afford her. She was literally like living there for 6 weeks, and they didn't really afford her any of like the basic decencies that we would have wanted for ourselves to wear our own clothes. So I think there's many things that we can do. I think it's very interesting too to think about, like when I was in Boston, there was a hospital called the Faulkner, and they had like a special wing that was dedicated to treating addiction. It was like a level 4 detox, and they had special nurses that like cared for addiction. And so in every hospital I'm in, we're like, oh, we should like really create that. Like, wouldn't that be great? But at the same time, like the worry is like that creates, stigma, and we really need to train everyone up to care for people who use drugs. I mean, it has to do with our larger cultural discourse in which we're steeped, which is to hate and disbelieve, distrust, dislike, and think people are bad who use drugs. Like we have to unlearn that. Like that is something that we all are steeped in, and we have to unlearn that, actively unlearn that, because everyone has, some of these beliefs. And so I think we get that from media, we get that from language, we get that from, all TV, we get that from all of these depictions. So all that to say is there's a lot of practical things you can do. You can have like messaging that says like drug user friendly, or like we accept you for these things, and you can have a lot of signage. You can have things in your way. For example, like there's waiting rooms at Bridge Clinic at Mass General that have, like safe supply, like safe equipment that people can access, right? I mean, having things that are welcoming, like things that people want and need. I know that like every time that I would talk to some people in my book who came to the hospital, they would literally take everything out of the drawers because they literally had nothing, they had no towels, they really wanted to like have all of the towels and things like that. Like they needed things. And so I think there are ways we can be much, much more welcoming and accommodating in our clinical spaces. And then getting out of our clinical spaces, like I mentioned before, is really even more important. So getting to under the bridge, going to the encampments, like really, really meeting people where they're at, I think is critical. And I think, and that is humanizing. And that is where I think we need to go. I think the next level of care needs to be like, how do we mobilize, liberate people from the clinic, so to speak? How do we bring the clinic to the people? How do we have models where we, street medicine teams where we go out and we have HIV meds, or you need antibiotics, I have a Zithro, or you need this, like how do we need those scaled up, or you need methadone, or you need whatever, like how could we do that? Like how could I put on a backpack and have 20 essential meds and take care of you? And how could I prevent you from having to go through? Many times when I was training at MGH, I'd be like, okay, so you have to be admitted, you have to go through the gauntlet of the ER, you have to wait 30 hours, you have to go because you have, these conditions, XYZ, we have to do this in the hospital, but maybe I didn't have to do it in the hospital. Maybe I could have done it at her house. Like how could I have brought it to her? So like, there's a lot of things I think that we could do more of.
There's a question, I'll just read it aloud. This person asks, I understand harm reduction as a true ecosystem of systemic and person-centered supports, and the data seems to support that too. How do we bridge the gap between the extensive data about behavioral health and substance use and resources and the institutions that seem to refuse to hear or internalize it? Bridging the gap.
Bridging the gap, okay, between evidence of harm reduction and our institutions
that refuse to hear it.
I think this is where stories of like, as narratives really are critical. Like people telling stories of people who are alive and thriving because of harm reduction. I mean, I find them, New York City had a campaign that was like, naloxone saved my life, or like, I naloxone my best friend. And it was really powerful. They used real people, they used real stories of like, I'm alive because someone gave me naloxone, and they're wonderful. Like they're real, and they have like a little vignette, and they were really humanizing. So I think public health departments, I think really that this idea of that, that Brandon mentioned of hope, like how people are resilient, people are creative, people are wonderful, and like really do often, get to places where their substance use is stable, where it's minimized, where the harms are minimized, where they're able to use them safely and live the kinds of quality of life that they want. I think people don't believe it. And there's this whole campaign. I mean, Ingrid Walker, who's a professor at University of Washington, and Carl Hart, and a bunch of other people are trying to say like, look, I use drugs. Like I use drugs. Ingrid Walker, is like, I'm a professor, I use drugs. Carl Hart's like, I'm a professor, I use drugs. And I always tell the story of William Halsted, one of the founding fathers of modern medicine, the surgeon who created, some of the initial techniques for breast cancer. Antiseptic technique is related to Halsted. He was a very chaotically morphine and cocaine, user throughout the time that he did surgery, and throughout the time that he contributed immensely to founding the pillars of like medicine. So like, if we believe that people who use drugs are worthwhile, despite or in spite of, or whether they are or are not using substances, and that they can be productive and create, contribute meaningfully and deserve to live and deserve to have freedom and autonomy, like those stories need to be told. So I find that really compelling, the argument being like, we should talk about substance, like people who are privileged need to talk about substance use in order to just say like, I use whatever illicit drug, and to sort of destigmatize our deeply ingrained notions of like what it means to be like a heroin user, et cetera, like that, and to shake up in our minds, because I think that people persistently think that it's a negative thing, or that people have problems, or that they can't be functional. And we know those not to be true.
Great. I'll actually ask the members of the audience if you have any questions you'd like to ask this time. I might have to ask you, since I have moderator's purview. I was seeing that you did have a request for a boat, for a SIF boat.
Yes. Okay. Yes. Mm-hmm.
But to follow on that question, state of Rhode Island is undertaking regulations and thinking about harm reduction centers. What are your thoughts about mobile? Mobile has expanded so greatly in the time of COVID, and mobile health units, backpack exchanges, part of our bread and butter syringe service program access here. What are your thoughts about smaller programs that might be more mobile for harm reduction efforts like a safe consumption space? Yeah,
I think mobile is wonderful. Like I think it could be, in many ways it's cheaper, it's nimble to kind of overdose hotspots. You solve the problem of, you don't solve the problem of NIMBYism per se, but you diffuse it. I think having, Brandon and I were talking about having multiple operators. And I think having, I think that also will increase like the range of services might be different, the approaches. Some prevention, overdose prevention sites in Vancouver are women only. I mean, there's a wide variety. It gives you, I think, an ability to be more nimble and to really seeing how people use drugs. I think seeing if you could design it for the way that could enhance how people actually use drugs. So one example that I would say is I was in Vancouver, and they were like, oh yeah, we had these like individual booths, but a lot of people use drugs in twos, like really run with people, and like inject, people inject them, and they check on each other, and they're using together, and they're kind of, so they realize like these booths, like really two people wanted to sit at the booth, so I think it's really important to figure out how do we create spaces that are informed and designed by, led by people who use drugs. Like how could we envision a van? Where would they want to use on this? Like if I had this tricked out van that had like a bathroom and like a clinic space, like, some like a clinical van, like where would people want to use on that van? Or like, in what context and when, like, should the van be, open at, the peak times, which are, in Connecticut, they're often like nights, and they increase, the overdoses increase like Thursday, Friday, they kind of increase at the end of the week. So like that does, I think, allow you to be a little bit more nimble than having a fixed site with a lot of costs. And St. Anne's Corner of Harm Reduction in the Bronx, where I saw patients in New York, they really wanted to be a site, and they wanted to have a pharmacy. They already were going to be 24 hours drop-in, but it comes with a lot of staffing. It comes with a lot of overhead, I think, to have a fixed site. And certainly they were already positioned to be it because they were already an SSP, and the neighborhood kind of knew them already, and the same people, came already. But I think it also prevents the problem of like, I don't even know if you call it like a honeypot, but like it diffuses, like substance use is happening in many areas. I think also thinking about if someone's going to go use a spot, like how far will they travel to go use a spot, and like if they're an opioid withdrawal, like are they going to travel? Would I walk 4 blocks? Would I walk a mile? Like how far from where I procure drugs would I want to go to use them? And then also the problem of, this is not one of my problems, but like the public health problem that many of you care about in this room is of people using alone, at home. How do we make those places safe? Like if I was, I really think that is, many people want to do it in the privacy of their home. Many people, that's convenient, private, for them feels safe. And how do we make that as safe as possible?
Uh-oh, you have one more question. Yeah, let me take.
Thank you so much for all your insights and sharing your experience. I just had a question. I was hoping that you could speak to all the hackers as to the central role of mental health and trauma patients. I'm saying patients, I'm a clinician, sorry, and people who have substance use disorders. Are there hacks that you think are there for the taking that deal with trauma and mental health?
That's a good question. As I think you're inferring also that, it's very common. I think thinking about some of the hacks that I might have. I think sometimes in the hospital, I see a lot of patients who come in with, let's say, a mental health crisis, suicidal ideation, or a suicide attempt because of chaotic substance use. And they're not necessarily saying like, I want to die, but they're saying like, I need help. I'm at a place where like, I can't maintain anymore. And so I think trying to figure out how we can provide those supports and get those supports to people before they end up in the emergency room would be great. I think, I would wonder if there's a way to set people up with peers, like if there's a way that you could hack people with lived experience being the front line of sort of crisis intervention and de-escalation, and ways that people could, I know there's a lot of crisis hotlines. There's like a lot of suicide hotlines, for example, but I think specifically for people who have lived experience of substance use is a particular subset, of, let's say, people who are having a crisis leading to suicidal ideation. So I would think trying to get peers involved, trying to have sort of nimble teams of clinicians. Even the problem of people who are having a mental health or substance use crisis and get killed by police. So how do we hack that problem? And I was on the phone with someone yesterday who was like, are there models of other programs around the country that are nimble to responding to someone, who's chaotically using meth, who's waving like a sword, and like how could you envision a hack where that person doesn't get killed by the police? Because that would be that would be great, because that's often a system of, it's often a structurally racist system. It ends up being, it has a lot of implications for people that are really in like a temporary state that might be caused from drugs, or and how do we envision a different system? How could we envision a different 911? How could that get triaged differently? How could that get handled differently? Who could go out and handle that? Who feels equipped to handle that? What level of, I was talking to this person and I was like, well, I mean, some people would feel comfortable running into a room with someone on meth. There's some harm reduction programs that have these like there's meth sobering centers, for example, in San Francisco and the West Coast, where people just, go hang out, and, and the people who run those feel very comfortable with people who might be having psychological symptoms of meth, like paranoia, psychosis, auditory or visual hallucinations. Like, what level of training do you need to feel comfortable with that? And I'm like, harm reduction centers are like a wonderful space to like prevent people from being killed by the police for like acting erratically. And so like that is maybe one hack, but like what are other hacks we could do?
We have time for one more question, and then we're going to take a break. This question, it's coming in through the feed. The question is, street medicine is so vital, but qualified doctors are already burnt out, and getting the number of people to meet the need to do outreach at camps doesn't seem possible. As harm reductionists that have a history of operating in gray area to help people, what can we do?
They're trying to, all of these questions are like, these are questions for you. Like, these are like, I don't know the answer to these questions. I mean, I think there should be, okay, so that's multiple questions, actually. It's a question of, I think, burnout. It's a question of supply. It's a question of re-envisioning care models. I think having allied practitioners who aren't doctors is essential. I really don't care if someone's a peer or an RN or APRN or a PA. And I really think we need to do a better job of training allied health professionals. I think burnout is a real issue. I think the issue that I mentioned about trauma and grief, it does affect us as clinicians as well. And there is some secondary trauma from having your patients die in their 20s, 30s, 40s. Like that is, like it is a hard field. And I was talking to some potential applicants for the addiction medicine program at Yale. And they're like, oh yeah, I just really like click with people, I just love talking to people who use drugs. They're just so real, et cetera, et cetera. And I'm like, I love that. It's great, but it's like a very tragic field to go into. Like it's a field where, like basically people our age, younger than us, people die like ahead of their time. Like, and we really, I don't think have, healthy systems of processing that. And so we're trying to kind of create communities or create groups where people can process that and continue their work, because it does feel really crushing. It feels very like Sisyphean to be rolling a boulder up and down the hill every time and trying to just, like, I feel crushed by it when people just call people abusers and, all this like terrible stuff. And like, so I do think that doesn't really necessarily solve the question, but I think trying to, street medicine is wonderful. I think it probably also has to do with, getting more funding for it, really publicizing it, really making it sustainable, really making sure that it's able to be sustained in clinic settings, and that clinics and programs are able to keep them up, and that they're seen as investments, that your community will invest in one, and that it'll pay dividends. So
Valuing harm reduction. Love it. Thank you for all these great
Of
ideas,
course.
hacks,
Thank
challenges, and
you. Thank
otherwise.
you all.
We'll take a break. Thank you. Welcome. Hope you had a little snack break or drink break there. We are excited to get started with our panel. So I'm Tracy Green. I'm from the COBRE on opioids and overdose at Rhode Island Hospital. Thank you for joining. If you missed any part of our kickoff events, I encourage you to check out the recordings. They'll be up on the AirMeet platform. But at this point in the evening, we're going to turn to our panel of exciting, innovative speakers. And I would like to introduce Dr. Alex Collins, who will be moderating the panel. And thank you very much.
Good. Can you hear me now? Okay. Oh, okay. Makes me uncomfortable. So our first panelist is Dr. Rachel Whiteman. Dr. Whiteman is a primary clinical physician and is in the evaluation and management of drug toxicity syndromes. And she is a emergency medicine physician here at Brown, an addiction. And she will be our first speaker on the Buprenorphine Hotline. I'm speaking here. Up there. Up there.
Oh, this is tall. Okay. Hi. Thank you so much for having me today. This is an initiative that's near and dear to my heart that came out of the COVID-19 pandemic. And my hope today is to talk about what we did with the goal to have lessons learned move forward and take the good things that came out of the pandemic as we hopefully move forward with it. All right. Oh, here's my remote. So just very quickly, I want to acknowledge the groups that supported this effort: Rhode Island Department of Health, BHDDH, the Rhode Island COBRE on opioid and overdose, as well as Lifespan. So before I get into talking about how and why this program came about, for those of you that aren't familiar, I'm just going to talk about what the Rhode Island Buprenorphine Hotline is and how it functions. So it is a 24/7 telephone-based, telephone-only bridge clinic for buprenorphine. And what that means is that anybody with opioid use disorder or in withdrawal in Rhode Island can call the hotline, and they get hooked into an access center that registers them and connects them in real time, no matter time of day, middle of the night, with a buprenorphine prescriber. And they have a telehealth encounter. So it's like a clinic visit minus the clinic. So pretty much the same things that you would normally have: history, substance history, and an evaluation to see if buprenorphine would be a good medication for them and a safe medication. And if it's found to be, they then get a real-time prescription for buprenorphine. And we additionally co-prescribe naloxone. We provide additional harm reduction services and referral and linkage to ongoing treatment. And right now, and pretty much throughout running the Buprenorphine Hotline, we've been 6 providers, and we've gotten extra help from the Rhode Island Hospital Addiction Medicine Fellows as well. And because it's a funded project, it's free right now, at least while we have funding. And that's what it is. And now I'm going to go kind of into the background of how this initiative came about, why it's so unique, and why this was never done before. So pre-pandemic, in order to start on buprenorphine, you needed an in-person visit. So you needed to see a provider in the clinic, have a physical exam before you could get a buprenorphine prescription. And in March 2020, related to COVID-19 and increased barriers to accessing care, HHS and DEA, they released regulatory flexibility around substance use disorder and buprenorphine prescribing. And the really important parts of this is that they waived that initial requirement for an in-person visit, and they also allowed telephone-only visits. And we saw this as a huge opportunity. And I'm going to kind of go through the steps of our reasoning, why we thought this was such a good idea to try to provide to the people of Rhode Island. So this is the data that was out there for buprenorphine telehealth before the pandemic. So it had only been used for maintenance treatment, never buprenorphine initiations. And this is data from University of Maryland and West Virginia that showed this similar treatment outcomes to in-person care for telehealth delivered buprenorphine. And in the West Virginia article, they not only looked at telehealth delivered buprenorphine, but they also compared it to their in-person clinic care and had similar treatment results. And there's similar data across veterans, across obstetric populations, where telehealth buprenorphine was actually incorporated into obstetric care and had similar maternal and fetal outcomes compared to in-person care. So we knew that there was data that buprenorphine delivered via telehealth had similar treatment outcomes. Additionally, we knew the safety profile. It has ceiling effect on not only opioid effects, but also respiratory depression and CNS depression. So what kills an opioid overdose? We also knew that diverted buprenorphine most often is used to treat withdrawal or because of access problems and stigma. And we knew that the same PDMP kind of guardrails would be in place when we prescribe via telehealth versus in-person care. So we felt confident that this would be a safe way to deliver buprenorphine. And additionally, unobserved buprenorphine initiations were really taking hold and showing good data of efficacy. So ASAM, ASAP, we're all advocating unobserved initiation. So us prescribing and having people start buprenorphine wherever they were was an evidence-based approach. The other thing that I took from my own kind of personal experience as a medical toxicologist, I trained at a poison center and I took poison center call. And when you work at a poison center, you're giving telephone only, audio only consultations over the phone to patients, to parents, to providers for complex poisonings and environmental exposures. And so I knew that really high quality care could be delivered over the phone and that you could really talk with people, get to know them and be able to deliver good care. So based on kind of that knowledge block and the new regulatory changes, we set up the Buprenorphine Hotline. And the goals of the hotline were to provide low threshold buprenorphine access. We knew that there were barriers based on income, geographical barriers, barriers based on insurance status and race to buprenorphine access pre-pandemic. And we knew that those gaps in access of care were only going to be exacerbated with COVID-19. So we made the hotline 24/7. We had full interpreter services available over the phone for patients, and we made it free. We wanted to reduce stigma in order to maximize harm reduction approaches. And not everybody wants to be seen in their environment at any moment in time. And so the audio only option really lets people call wherever they are and kind of takes that element out of the equation. And I had people call who had never ever before accessed substance use disorder treatment because they felt comfortable picking up a phone and talking to someone where they didn't feel comfortable going into a clinic or necessarily being on video. So we really kind of were able to break through some barriers with this approach. The other thing we wanted to do and why we went telephone only was that we wanted to improve equity in addiction treatment. And we knew that there's a digital divide. So there are disparities in who has access to high broadband, who has access to smartphones, phones with good data plans. Because if you're going to use an audio-visual platform and you're doing it over your phone, you don't only need kind of the app and the resources to be able to do it. You need that good data plan and you need to have minutes and funds to do that. And with closure of public spaces, we knew that public Wi-Fi was going to be less accessible. All right. So that's what we did. And this is preliminary data that's kind of, we're hoping to put out more detailed data and hopefully get that published soon. But this is from the first 9 months we ran the hotline. And we had 131 unique callers. We prescribed 95 new buprenorphine initiations for unobserved starts. And of those prescriptions we provided, almost 94% of them were filled. So people were not only speaking with us on the phone, but they were going to the pharmacy and they were picking up their prescriptions. And we had really good follow-up. So these follow-up numbers are actually better than a lot of the clinics in the area for in-person retention and care. So we did our follow-up because we were referring all throughout Rhode Island. So we were directly connected with the Lifespan Recovery Center because we used their access center to register patients. We could directly get someone a clinic appointment there, but based on where people lived or where they wanted to seek treatment, we helped link them to resources all across the state. So we used the PDMP follow-up data on whether or not they had a repeat buprenorphine prescription within 30 days, and then also 6-month follow-up data of repeat prescribing. And I'd just like to especially thank my partners on this project, Dr. Samuels, Dr. Wunsch, and Dr. Clark. And thank you so much for having me and letting me share this experience.
So our second speaker today is Gordon Casey. After 15 years as an entrepreneur and lawyer in the financial services sector, Gordon now works on the Brave Technology Co-op, which is a platform for folks who use drugs to stay safe and alive no matter where they are. So.
Hi. It's not on? I'll wait. 1 minute. So yeah, my name is Gordon and I work at Brave. Brave is situated on the unceded and stolen territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. I'm a settler there. That's also known as Vancouver, Canada. We also have an office in a place also known as Columbus, Ohio, which is the traditional Shawandas Tula, Shawnee, Miami, and the Hopewell Nation territory. And I look forward actually this weekend to looking up some of the ancestral territories that I'm on here while I'm in Providence. I don't know much about it. Most of these figures are familiar to everybody here. About 100,000 people died last year of preventable overdose between Canada and the US. People use drugs for all sorts of reasons, and those drugs might result in overdose due to a variety of factors. But as Dr. Kim said earlier, every one of those deaths was preventable. The reason why people die from an overdose is pretty singular, though. And that's because we didn't get there in time. Most of the time, we don't even know that it happened at all. We need to do so many things. And those 2 slides of the things that keep Dr. Kim awake at night are the beginning of all the things we need to do. We need to have more safe injection sites, more safe consumption sites. We need a safe supply. We need to ensure that people are aware of what is in the substances that they're consuming. But even if we did all of those things, it is still not enough. We need to do more because people will continue to use these drugs. They will use drugs alone. And because of that, they will overdose and they will die. So the question is, for us, for Brave, and I invite everybody else to ask this question, what can we do now for the people that are using drugs today and that are going to overdose today, and that can be made accessible to them right now? Brave's framework is to try and detect overdoses. We believe that if an overdose can be detected, then it doesn't have to be fatal. And although this is what we've been doing for the last 5 years, the actual language around it is new to us, which is why I wanted to share it with folks today. I think it's a framework that allows people, all of us collectively as part of the harm reduction movement, to have a fuller spectrum of solutions from prevention through detection all the way to response. To date, we've detected 104 overdoses at Brave. And that's through, these three tools. It's an app for people who are using at home alone, a button for people in supportive housing, and a radar sensor for places such as washrooms. In addition, we partnered with a group in Ontario to launch a Canadian phone line. It's a copycat of the Never Use Alone line. And it's this t-shirt I'm wearing today. And they've also detected 39 overdoses to date. And I know that Never Use Alone has detected right about 30 as well. So collectively, these very new and pretty unfunded solutions that are out there have detected close to 200 overdoses in a really short period of time. And it's because of, I believe, it's because of this framework. So that's it. This is kind of what I have to say. For those of you who are participating in the hackathon, I'm around all weekend and I'm happy to, I'm available for anything. Brave is a cooperative, and so this is my last sort of piece for you, especially if you're thinking of considering going further with your solution or your innovation. And we're a cooperative that is owned by the people who use our technology and the people who work on the team and anybody who happens to invest financially. So essentially anyone who's contributing to the success gets to own the organization. And our co-op, the team that actually works on it, is made up of this really unlikely collaboration of people. There are drug users, there are sex workers, there are engineers, there are entrepreneurs and people with lived and living experience. And all of us sadly have lost friends to overdose. Almost all of us have responded and revived people from overdose as well. Literally hundreds of people collectively from our small team. And we've lost people on our team to overdose as well. So it's been sadly the full gamut. Thank you.
So our third speaker is Lieutenant Stephen Murray. He is a lieutenant at the Regional Ambulance Service in Western Mass, and he has served Berkshire County as a first responder since 2013 as a firefighter and paramedic. He shares his lived experience as a person who used drugs, as well as his professional experience on the front lines of the overdose crisis. He is the director of Never Use Alone, Massachusetts, New York, Vermont, and a grad student of public health at Boston University.
Hello. Oh, all right, hold on. Hi, thanks for having me. It's really exciting to be here, meeting a bunch of people that I know through the Twitterverse. It's been a real highlight. So as Alex said, my name is Stephen Murray. My main day job, I work as a frontline paramedic in Western Massachusetts. Our agency covers 265 square miles of rural Western Mass and Southern Vermont. And I've responded to a lot of overdoses. In my career, I lost track, but it's over 100. I've been the guy that has to tell, parents and family members and kids and loved ones that their person is dead. And that I carry that weight with me everywhere. And I think that one of the reasons why I carry it so much is because I'm also an overdose survivor myself. So it was inevitable, I think, that someday I would become able to come out and talk about my recovery and find ways to move upstream in the process. Being a paramedic, like the old public health adage of like fishing people out of the river, like I am the guy who's stuck in the river all the time. And so when I became involved with Never Use Alone, it was like something that actually is going to help prevent me from having to do my job. So what is Never Use Alone? So Never Use Alone is the American counterpart to Brave. We have a really great relationship with our friends. We're a virtual supervised consumption site. We connect people who use drugs, and Our operators are amazing. We've taken more than 4,500 calls. We've had 28 overdoses on the hotline. And our more than 50 volunteer operators are around the country. And it's really an exceptional group of people. And I think that a couple of things that Dr. Soo said really resonated with me, which is that, you know, what happened at the very beginning of the hotline was that one of the hotline operators was a person who was in recovery. And when she had a recurrence of use, didn't feel comfortable calling the hotline herself and talking to her friends because she didn't want them to know that she was using again, and she died. Her name was Mandy. And because of Mandy, we have a very upfront policy, which is that people who are currently using are able to be hotline operators. We don't have an abstinence requirement. We're not a recovery hotline. And so it's pretty amazing. We ask our operators, like, if you wouldn't be able to drive a car, like, don't answer a phone call. It's really easy to hit pass and move on to the next operator. But our operators are people who someone put have living experience. And it really is amazing to listen to these calls. So our service is free. It's available 24 hours a day. It's a 1-800 number. So one of the things I love is that, you know, if you had a phone that didn't have minutes on it, for example, you could still call. If you're on a public payphone, you could still call. We are really good at helping to help people think about, like, how to make their positioning more safe for themselves, for first responders, for pets. You know, the worst thing is, like, you overdose and the police come and shoot your dog. Like, that's not something that is a good outcome of an overdose. So we ask people to secure their pets, to put away any drugs that they're not using in the moment, to hide them out of sight, and to move away from doors. Because I can tell you, I'm really good at breaking down doors. I break down a lot of doors. I really enjoy it. But I can't break down a door if you're sitting up against it. I have to call the fire department, and they have to actually take it off the hinges, because it's impossible basically to break, unless I can break it in half. We have to get the door off the hinges. So if you can ever tell people, like, don't sit up against doors for using, sit across the room, it's much, much easier for us to get to you. So that's just a piece of experience that I brought to the organization, that we try to implement some of my knowledge as an EMS provider. We also are able to get people connected with syringes and other harm reduction materials. And many of our callers have become operators, which is really cool. It's like the cycle, because you don't have to be abstinent. You could call one day, and then the next day we train you to be an operator. And it's a really great self-sustaining model. So community engagement, I pretty much present almost every week to community groups. My counterpart, Jess Blanchard, who's the director of education for the national organization. She and I both are all over the place, thanks to Zoom, making presentations to community and tribal coalitions, hospitals, addiction medicine groups, primary care providers, treatment centers, detoxes, jails, prisons. And it was really cool because the Healing Community Study, which is like this federal money, adopted us as an intervention, which I thought was really cool because supervised consumption sites aren't really legal. And they let us put up these bus ads in Brockton, Massachusetts. And this bus goes into a high overdose area. It was up for 3 months, and it was pretty cool. It did increase call volume in that area, so it was something that was worthwhile. So one of the things I like to remind people, so the list on the left is the list that I think most of us are used to seeing. So actually the list on the left is what's adopted from, like, Massachusetts Department of Public Health, their list of risks for fatal overdose. My list on the right is unfortunately from lived experience. And the one I'm going to highlight is, and the reason I bring this up is that one of the things we have to think about is we have to get a little bit more creative with who we're reaching out to prevent overdose. And so one day, a police officer called me from our town and he said, "Hey, we just arrested this guy, and he's going to be locked up for the whole weekend. It was a holiday weekend. And we're really concerned about his girlfriend who he was beating up because she's going to be using alone for the weekend while he's gone. So he's removed from the situation so she becomes more safe from not being near him, but she becomes less safe because now the person that she uses with isn't there anymore." So what was our solution? We got her hooked up with Never Use Alone, and she called the hotline all weekend. It worked, kept her alive. That's the type of thinking that I wanted to encourage people to think about. Like, so when we talk about, you know, someone who is at high risk because they just came out of detox or residential treatment, when not just is that person at risk, but the person who's left behind is at risk because now the person that they've been with. So I want people to get a little bit more creative on how we think about who's at high risk. So where are we going? Our 501c3 application is in progress. We have formed a board of directors, which is this beautiful group of people over here. And I'm really excited that actually we're going to be shutting down the Vermont hotline and creating Never Use Alone New England, which I'll be the director of. And so we're really excited to be working with our peers here in Rhode Island. We're going to be trying to expand the amount of cards that we're giving out here. So if you're from like a syringe exchange or you're somewhere where you can give out cards, send me an email. As soon as I have them, I'll send them to you. We are also launching a Spanish hotline, which has been on our list to do for so long, but we had to get like a critical mass of available operators who could take calls in Spanish, which was not as easy as it sounds. And we also hope to ensure our operators reliability and be able to pay them cash stipends for taking calls to encourage taking calls in the off hours. So I think that we're an essential part of the harm reduction toolkit. And I like that Dr. Soo drew this difference between, like, we're both a harm reduction, lowercase toolkit intervention, but we really embody the spirit of the harm reduction movement, which is that we're drug user led, we're drug user organized, and we really don't push recovery on the hotline at all. We are a safety line. We don't, this is very much caller driven. The caller drives the conversation. And I think it's really important because people, like, if you think about our statistics, right, we've had 4,500 calls, 28 overdoses. 99.95% of our calls end uneventfully. So what happens on those calls? Like, beautiful things happen. Like, people are talking, they're connecting, they don't feel isolated. They are, engaging in a way that maybe they're not accustomed to. Like, you're talking to someone you've never met, you're having this like really deep conversation about your life, and they're not pushing you towards treatment, and they're not making you feel like you're a bad person. And so I think it's really a model for that. And then the final thing that I'll just share with you is that I had the experience of responding to a Never Use Alone hotline overdose myself as a paramedic. And that was a really crazy experience. There's a video where online you can find where I talked with a young woman who had overdosed. But I got to be out of the stream and in the stream at the same time, and that was really cool. So I think that's it. Thanks.
Our final panelist is Senator Josh Miller, who represents the District 28, which includes portions of Cranston and Providence and the Rhode Island Senate. Senator Miller was a driving force behind the enactment of legislation providing parity and coverage of mental health and substance use disorders. And he has championed a package of legislation addressing the mental health system aimed at improving preventative services and treatment, as well as a package of legislation addressing the opioid overdose crisis.
So how do I get this to, okay, I want to start with that one, because that's part of what she described with being a legislator. And I want to kind of fit this into the context of where we started, what good came out of COVID. Because what I'm going to talk about, if we can navigate to there, is the good things that came out of COVID. So one of the good things that came out of COVID was legislation that we really only imagined might pass, but actually did pass this year. And this signing ceremony, this is a porch at the State House that this is taken off of. That was a signing ceremony for 4 bills that passed in June, but the ceremony was a week or 2 ago. And you can see 2 of our friends, a rep, and 2 of our friends from Project Weber Renew, who were so instrumental in much of this legislation. And I asked Kaylee to stay because she was part of all this, but she snuck out. And a lot of people in this room were really part of all this. So one bill that passed and was part of the signing ceremony was Senate Bill number 4, which was telemedicine. And we imagined this might pass, but we didn't imagine that it would become so significant in the context of COVID. And then we were worried that it wouldn't pass because it was Senate Bill number 4. And I say that because as chair of the Senate Health and Human Services Committee, I get to plan what we hear when. And we heard that bill in January along with the harm reduction legislation and the buprenorphine decrim, which were also part of this ceremony. And they were one of the first hearings we had because of the COVID component of them, right? That we had to indefinitely continue telemedicine. That because of the syndemic, as many of people have been discussing, we needed to pass harm reduction and we needed to pass decriminalizing buprenorphine. And a lot of these bills had been out there for years and didn't pass except because of the pandemic. And rather than the community of people like this group that works on these issues all the time, because of the pandemic and the context in which these things were discussed, they got understood by a wider group of people. So these things that felt virtually impossible became possible. So another thing that happened to me during the pandemic and that I worked at during the pandemic was I became chair of a group called the Downtown Improvement District. And there are downtown improvement districts and districts like them across the country that do mostly what we call clean and safe, which is beautification, litter control, and security. There's a security component to it. And so this guy in the yellow jacket, we call him the yellow jacket. I took this picture one day. I actually went around the block to get this picture because it demonstrates a couple of things. One actual and one discussed around the pandemic is their ability to be in the right place at the right time and help this woman who was stuck on a corner and couldn't figure out how to get across the street. Looks at least, octogenarian and minimal. And you'll see on the bench there, Kennedy Plaza, this picture was taken, as many of you might recognize. And many of these people are homeless or SUD or seriously mentally ill. And what we were able to accomplish, as I put it into kind of hyperdrive when I became chair of this group in July, was we finally got the bathrooms open. During the pandemic, the bathrooms were closed. And as somebody who has learned over the last decade or so how to scream and yell a lot, I literally had to scream and yell almost at least once a week, if not several times a week, in order to discuss with people who should have known better that there was a health component to having a public bathroom when all public access to bathrooms was virtually closed. And it took a year, but we got it done. The other thing we got done literally last week was we reprioritized based on return to work. Sometimes you have to add some language in these things to get them done. Return to work, return to venue, homeless, the presence of homeless people in SUD and seriously mentally ill dramatically increased in this downtown footprint, which is only a few blocks from here. It dramatically increased. So we finally, after almost the same pattern of advocacy for the bathrooms, we now have a collaboration with the Rhode Island Foundation, Crossroads Rhode Island, who hasn't had outreach for 3 years. You had to come to Crossroads. Now we have a collaboration with city ARPA funds, private stakeholders, the DID, and about a half a dozen others to fund outreach. That includes not only, and this will probably actually be in place before the end of this year, at the longest. More security, the outreach component that will not only include homeless, because that's a fraction, a large fraction, but not the only fraction of those sitting on that bench. Some of those have housing, but are in a mental health rut or a SUD rut rather than a housing rut. So they'll collaborate to get those services. So that's another virtually impossible before COVID, now possible because of COVID. Where's the last slide? There, no, there. Nope. There we go. Okay, so my third part-time job is that I own Trinity Brewhouse, which is also about 6 blocks away, and it's a brew pub. And the good that came out of COVID is we had a crisis of hiring, and I have done this since several years ago, but it became a crisis, and therefore it was more of a necessity rather than an option to focus on hiring for those who are in recovery. I took this picture about a week ago. We haven't been open every day, and partly because of these people and a few others, we're going to be open every day next week. And it's always been a struggle, but also some of the most rewarding things you can do as a boss is focus on hiring those who are in recovery. And almost all of those, if many in the room might know Jonathan Goyer, who now runs the recovery workplace effort in Rhode Island. And so it's incredibly rewarding, but incredibly difficult to navigate these people. I'll be totally honest with you, but it's worth it. And I won't identify them directly, but one of these people, since we hired her, we hired her the day after she came out of inpatient. She went back to inpatient and came back out a week ago. And she's really talented at this point. The rest of them are relatively new and have relatively different experiences. But if I was to be a hackathon participant, and this goes to those people and the people you don't see in this photo, one of the things I would look at is treating the undocumented and having access for the undocumented, as well as we can have access to treatment and recovery for those who are not undocumented, because we literally had people during the same period that we tried to help and we tried to help ourselves because we wanted to fully reopen, that couldn't work for us because they couldn't access transportation. They couldn't only work day shifts if we wanted them to work, because RIPTA, our public transportation, virtually is not useful enough late at night for them to get home, and often to where their recovery housing is, where they're. And so one of the things, if I was hacking, two of the things would be to the culture of getting the same amount of services and the barriers for people who are undocumented, but also around transportation. I think it's time for something, and it works for a wide range, and we talked about it before COVID and there is some of this in place, but not as comprehensive as I would imagine, that would basically function for recovery and treatment services, and to get people from their housing a state-run Uber account. It would open up so much access to treatment and so much access to employment if we had a statewide Uber account. There are some of the services that are using this, but not to the level that would really make a radical difference. And that's one of the challenges I think that anybody looking in this realm should consider. That's what I got. And this is my version of PowerPoint. I knew I was going to be the only guy without PowerPoint. And then I said, can you PowerPoint 3 photos if I give them to you? And so this is my version. And I think they really show three very important access. You write a bill, it might actually get passed. With or without a pandemic. Take on some volunteer work that could have a radical impact where there's been virtually none because of the old guard that was doing it in the past. And sharp disposal is another effort that looks like it's coming to fruition downtown based on Ocean Care, Ocean State cooperation and Parks Department, all these people who kind of sort of work together that are now forced to because of a crisis. Thanks.
Thank you so much to our panelists. I think we have a time for just a couple questions. There's one that I believe was submitted virtually from Lori McDougall. And this one's for you, Dr. Whiteman, but if others can chime in, that'd be great. So Lori asked, I'm wondering if you saw the breakdown of barriers to access to BUP in the Latinx and Black communities with initiating BUP via telemedicine.
Is this okay?
Yeah,
I can talk, sorry. I don't do very well talking through a mask. With our hotline, we tried to increase access and lower barriers as much as we could. And I think one of the things I really learned through working on the hotline was just how much flexibility we need to learn how to build into not only substance use treatment, but healthcare. The number of patients that I had called that missed a clinic appointment and couldn't get a bridge script, and their providers, luckily we were available and sent them to us to provide that, or people who tried to access care and couldn't be seen for a week or two and were calling to get a bridge script to get them to that clinic appointment. We saw people whose clinics closed and didn't know where to go and didn't have access. And so we were able to connect them to treatment. And I think that flexibility that gets brought in of having a service that's available after hours so people can work and they can live their lives while being treated for a substance use disorder, and just lowering the barriers. So not everybody who calls the hotline has to want treatment. They could just want treatment for withdrawal that day and get a prescription to treat their withdrawal at that moment in time. I didn't exactly answer about communities. Apologies about that. With the hotline, just looking through our data of who we really served, I think we served about 40% of the people that called were non-white. We actually had a good number of people who are older call the hotline, which I thought was a really hard population to reach. And so I think it was a great resource. I don't know if it was having just a phone call available that really opened things up to that population. But I think the more that we can do to make services work for people in their lives and not have it be this thing that they have to adjust their lives completely in order to get to services and get to treatment, it's really, really important.
I might use moderator privileges as well and ask one question. And this one really is kind of for Gordon and Stephen. These are interesting innovations that involve a lot of buy-in from multiple folks. And I was just wondering if y'all could speak to kind of the processes, like Gordon, how did you build these relationships with supportive housing providers or the public washrooms where the sensors are placed? And similarly, Stephen, how have y'all built out this network across the United States of people willing to, donate their time?
You first? Well, I kind of insert myself into as many meetings as I can. I don't really say no to any invitations, and I think that's important because you never know, like, sometimes I'll go to a meeting of very like hardline abstinence recovery folks, and you don't go into that meeting thinking that a harm reduction safety line is going to be like an effective discussion to have, but it's amazing how many times I'll get like an email after from someone who didn't like say anything during the meeting, but they'll send me an email after like, hey, that really opened my eyes to like to harm reduction. And so like, I think that as we shift the American obsession over abstinence treatment to being something that's more reflective of like what recovery should look like or what recovery could look like, we need to push ourselves into those circles and say like, hey, this isn't actually the only way. And like, I'm a person myself who's in abstinence or based recovery for more than 10 years. And I'm telling you that it doesn't work. So because everybody I went to rehab with is dead. So I think it's important to acknowledge that like people like me are an anomaly to make it to this point. And so obviously the system that we have in place doesn't work. And so I guess to answer your question, like we need to challenge this. We need to challenge this belief, and we have to, as harm reductionists, because these are harm reduction services, like we have to be willing to go into maybe uncomfortable places to have these discussions with the police. I mean, I regularly have to have these discussions with police groups, trying to get them to hand out our cards. And a lot of them do. So we can find allies that we didn't think we had and maybe make a difference.
I'll answer what I think the question was, or the way I'm sort of hearing it. The standard startup advice is to get out of the building. And that's because most folks who think of an innovation in the context of a hackathon or somewhere else we're sort of locked in a bit of a room. And so the advice is, get out of the building and validate your idea. In this context, what that means is to go and speak with people with lived and living experience of drug use. And then like, shut the fuck up and listen. Because your idea is probably like a great little nub of an idea. And if you're lucky, it will stimulate something back to you. But even if it doesn't, if you just keep your mouth shut, eventually you're going to hear something that you never would have heard otherwise. And you take that and you build on that. And so that's how we've built all these relationships is by learning to keep our mouths shut. The original idea for Brave was, and forgive me for this, but I'm doing it on purpose, was Uber for Narcan. So you find somebody who's overdosed, you push a button, an alert goes out, people who have Narcan nearby or naloxone will get the alert and come and respond. The worst place in the world to try and build that in 2017 was downtown east side of Vancouver, because they didn't need that right then. Rural Indiana right now, like that's still a viable thing, and that would still fly there. But what happened when I shut up was I learned that what people needed was a way to use it safely when they were alone. And so the Brave app came about. And then we spoke to people in housing and said, hey, this app, what do you think? People here. And then we spoke to the people in housing and said, hey, this app, what do you think? And they said, meh, not really. This thing is a tiny little button that we can stick up on your walls, and then people can just push the button, and then staff will know that room 203 wants you to go and check on them. How about that? And the context is like you push the button once before you're going to use, and then multiple times if there's something emergency like going on around you. How about that? Within 11 days of the first pilot, the first installation, there were 3 overdoses. So very rapid feedback that this was a thing that worked, meaning it made sense to the people that we were serving. And there was a lot of engagement that happened before that. And then people said, because we continue the conversations all the time, we're just talking and listening. They said, you know what, folks are overdosing in the bathrooms. We think that the buttons in the bathrooms would be a great idea. We said, okay, like great, so we stuck the buttons in the bathroom, and like nobody touched the button. Like nobody used them at all. And so then we listened to what some other folks were doing. So the Boston Medical Center had put these stillness monitors up in there. And we built a version of that. This is version 1, actually run version 4 right now. But this gets stuck up on a ceiling. It's passively monitoring the space. You can unplug it and plug it in a new space and all that stuff. And it's gonna send you an alert if somebody stops moving. And we thought that was really cool. And then they said, the way we actually try to keep our bathrooms safe anyway is by checking every 10 minutes. But we have 4 washrooms, two on this floor, 2 on the upstairs. So we're actually just constantly doing bathroom checks, and we're never actually complying with our own guidance, which is to be checking every 10 minutes. If this could just tell us, not just when people were still, but when somebody had been in there for 10 minutes, then that would be pretty cool too. So it's got a timer thing as well. So yeah, I'll shut up now.
No, that's great. So I think kind of key takeaways is listen, be nimble, and get out and talk to the folks, make sure that there's meaningful inclusion of people with lived and living experience. So, thank you and happy hacking.
Okay, we have one more panel coming up with some opportunity to hear from past hackathon winners. And we have a moderated panel with Jeff Capraro, colleague and friend from emergency medicine, who will be sharing a little bit more about his hack as well. And we'll be hearing from the 3 teams who won from last hackathon, the Mainstay, We Can app, and the Block MMP group. Come on up, Jeff. Yeah, come on up. Yes, we have both virtual streaming live who'll be joining us, and a couple in person who will be here as well. Welcome.
Great. So I'm so excited to be here to introduce you to the winners of the first hackathon 2 years ago. I suspect that everybody has a reason for being here today. And I suspect that those reasons are probably as diverse as your experiences and talents that you bring here. There's a very good chance that you're not going to have a better experience, a greater sense of collaboration with the people you meet, as you will with the people you meet at the hackathon here. I suspect you reflected on what you can bring here to the problems surrounding overdose and have some ideas of what those problems are. And soon you and your newfound colleagues here will define what the unmet need is that you're hoping to address. And the unmet needs are deep and wide, as we've been discussing. In the room, there are heavily funded NIH-funded researchers who are deeply respected scientists who might answer the question of what an unmet need is one way, looking at all the evidence and thinking about where the gaps are, what are the next logical steps. And the counselor in the room might reflect on her most recent client who has post-traumatic stress disorder and opioid use disorder and what their realities are. The business person or policy person in the group might think about the hundreds of billions of dollars that are lost on inadequately addressed substance use disorder in our country and say, where's the opportunity? Where's the best return on investment? And who's going to make that investment? The parents who have lost their adult child to overdose are going to give you some stark realities and gaps that need to be addressed. Each person in recovery is going to have ideas about the gaps in their past experience and their current reality and their near future that they're thinking about. I want to reflecting about what I have access to, what my reality is. I have access to naloxone in the emergency department. I work as an emergency medicine physician, and I know the power of that drug. And that's what fuels me to work on pushing naloxone and rescue tools as a public solution with Naloxbox. Through Naloxbox and related activities and the support of the COBRE for follow-on activities on stigma reduction, I've met those people in recovery. I've met the parent who lost their adult child. I've listened to all of them. And I'll tell you that it's been an interesting path. The path has included working with drama therapists and industrial designers and a physicist who loves communicating in cartoons. So you don't know where it's going to take you. But I will tell you that this is a caring community. of scrappy innovators who love to collaborate. And I think many of us in our professional lives will never have a better experience than working together with tight focus on what matters. So as I invite you to reflect on why you're here and what you bring and what the unmet needs are that you'd like to address, let me introduce you to the panelists who won that inaugural, and so they can share some of their experiences and perspectives. So Tobin, would you like to start? That'd be wonderful. Yeah, I apologize.
Can you hear me? Yes. Okay. Hi, my name is Tobin Shadlin. I am a strategic designer and researcher at the Center for Complexity at RISD, and I have a background in architectural design.
Hello, my name is Lee Hubbard. I use she, her pronouns. I am a registered nurse, and I'm currently the clinical manager at Open Door Health, Rhode Island's LGBTQ clinic up the street in the 02907 zip code. I came to the hackathon because of my work with Rhode Island Action Coalition, which is a nurse, getting nurses involved in leadership and activism committee, and met these lovely people, ended up on their team. And it's been a wild ride for the last couple of years.
Hi, I'm Tim. I also work at the Center for Complexity. I'm here because Tobin asked me to come. And my background is sort of an industrial designer, sort of a journalist. I used to make video games for a while. And we came together. I knew Tobin, but not all the people on our team were able to be here tonight. But most of us didn't know each other before the hackathon. And we came together because Hannah, who isn't here tonight, when you do the thing tomorrow where people say what they're interested in working on, Hannah said a thing that was interesting, and a bunch of the rest of us were like, "Hey, can we talk to you?" And that led to the collaboration. So I want to mention that because I want to say that I came with a bunch of people, and then we all split off to go into other teams because, like, you don't need a bunch of other designers. Like, you'll need like one. Like, you only need so many technologists. You only need so many clinical people on a team. It's better to find people who are different from you and work with them.
And hi, everybody. My name is Anthony Dutra. I'm a software engineer by trade, but I am co-director of Block MMP, and very excited to get started.
I think we have one winner joining remotely. Farshid.
There's the other co-director right there in Germany. So he is up late, everybody. Yep.
Okay, welcome. We'll figure out the tech. So I think, we are prepared to have each of you provide an overview of your startup. So if you're willing to provide that overview, and then we might have a couple of question and answers to follow.
Sure. So just a quick background, Tim had sort of alluded to it, but our team was made up of, well, actually it's changed over the course, but it was a quite interdisciplinary team of designers, technologists, public health researchers, a journalist, a nurse, so a community organizer. So it was a quite diverse team. And the group that came up with the hackathon first place idea was called Mainstay Rhode Island, Mainstay RI. And the idea was that many people, when they overdose, they're sent to the emergency department and they wake up from their overdose, either in the ambulance or in the emergency department. And EDs were never really designed for that kind of care for people who are waking up from an overdose, who are going through withdrawal symptoms and everything that goes along with that. And so the idea, quite a simple idea, was to create a space or a place for people to go to that are overdosing, that isn't the emergency department, that is designed specifically for the needs of people who are overdosing and all that comes with that. So that was the winning idea. I would say it's evolved since then. It was a very ambitious idea. I think there's definitely seedlings of a harm reduction center embedded in that idea. And so it's very exciting that that legislation has passed and that a lot of, I think, our research and our work since the hackathon, since that idea is hopefully going to inform some of the Harm Reduction Center efforts and decision-making moving forward. So there's a nice sort of collision and synergy happening. Yeah, that's a quick overview.
All right, yeah, and I guess jumping to Block MMP, we solved a pretty simple problem of the disconnect between opioid administration between clinics in Rhode Island. So basically what we did was we developed a very basic web application that uses blockchain technology to record each administration as if it was a transaction. And we are allowed to share privately that secured information, between our network of clinics that are taking part in becoming part of our software. So it's just myself and Varshith. We hired a team to sort of productionize the rest of the application to where it is today. So we can hopefully launch it in both the United States as well as out in Europe as a sort of co-project idea.
So
Yeah, is he there?
So next, we're waiting to hear from Brian Bishop, who's on screen with We Care, the Where We Care.
Yeah, Varshith first.
Work on solution to blockchain-based platform to track and record methadone dosage histories for methadone clinics in Rhode Island. And this was based on our conversations with the community that we had at the hackathon, and primarily with Dr. Heidi Peterson, who was one of the prescribers, and discovered this problem where there were a lot of logistical limitations in terms of tracking methadone dosages, and then risk of patients not being able to get the right dosages after these clinics were closed. So we looked at different centralized platforms like PDMP, and we saw that there wasn't a lot of oversight in who was actually accessing these records, and there was also a lot of stigma being created due to law enforcement being able to go in and look at these records. So Block MMP, we came up with a prototype, as Anthony mentioned, at the hackathon, and based on that, we were able to secure a second spot in the hackathon, and then we continued to develop our MVP and prototype, and then we eventually got in contact with one of the clinics, Victor, and also we have been in touch with one of the prescribers, Seth Clark. And so right now we are in the process of actually deploying the solution and getting our initial metrics for the MVP.
That sounds like some remarkable progress. I think we're going to try to tune in Brian Bishop next if he can be patched in. He's from.
Hey, I'm Brian Bishop. Just an introduction to myself. I'm a pharmacist by trade and have some data science and computer science background. So the app that we created last year is called We Can, and essentially tries to address a new medium for people to interact with, to learn about substance use disorder as a whole, not just necessarily about opioids. And the app kind of functions with three things, mainly education. An educator is someone who I think I am at heart. And we talk about ending the stigma, the types of substances there are, again, not just opioids, how to prevent a breathing emergency, and probably the most important education point is how to use naloxone, the antidote for an opioid overdose. We include some quizzes and some games throughout the application, and also attach resources. One of the ones that we worked quite hard on was actually where to find naloxone. So it's very specifically geared towards the state of Rhode Island, has locations, addresses, phone numbers for where you can find naloxone within the state, but then also just connecting people to resources they might not know about. So, working with the Department of Health to gather a list of those resources and have them in a different platform, not necessarily on the internet, not in writing on a piece of paper, on a mobile application, and kind of meet people, where we spend most of our time. So that is, in a nutshell, what We Can is, and we're continuing to develop it. We're still in discussions about, moving it and expanding it to, say, a state like Massachusetts or New Jersey is where I'm at right now. So we're working on still developing it. And we're all in collaboration still and talking.
That's terrific, thanks. So I just find it so encouraging to hear that there are hack groups that have had so much forward progress beyond the hackathon. I just wonder if, as you think back to when you first participated, if each of the teams could maybe share were the things that they might have liked to have done differently the first time around, other team members that could have fleshed out the team, advice to the people who are attending now to get the maximum bang out of their experience here.
Thank you so much. That's a great question. I think that Tim began answering that question for our team, which was, you may have come as a pack, but disperse, find new friends, and make sure that you've got a variety of perspectives on your team. I think the other thing that was really great about our team was we took every opportunity to ask questions of the subject matter experts that were kind of walking around and offering their expertise, people like Gordon. And then, the other thing that I think is really important when you start doing this is to come in kind of as an open vessel. You may have an idea that you want to work on, but be willing to kind of shift and be nimble and be flexible if you hear something else that really sparks a new idea or, that seems to be something that maybe you hadn't thought of, but that you can really contribute to. I think those are all things that that are really important. I think the other thing that we did, and we can maybe get into this as the panel moves forward, is our idea, while it seemed really simple, huge, huge, daunting. Let's just build a new place with all sorts of protocols and all sorts of technology where people can, it is a huge idea. And it's interesting hearing about the other teams that had a very laser focused idea. Two different ways to approach a very massive problem. So just kind of know what you're getting into, I would say, and also be aware of kind of the amount of time that you're willing to commit once the weekend is over. We spend every day together, not really. Every week though, we spend time in the evenings every week. Kind of furthering this discussion, working on an IRB project, meeting with key stakeholders, volunteering, and so it's passionate. It gives me energy, but the weekend is the beginning, not the end of this time together.
I think just building off a lot of what she said, it really comes down to listening and paying attention to what the process flow is and where can you add value to that process. We're not all technical. We don't need to be. Right, and the app is not necessarily the answer to every problem. So how can you work within the rest of your teammates in order to create something in a time frame that's actually feasible and will show up to last through time? Because I think we're all still kind of learning even after the hackathon what exactly our purpose is with what we've built.
That's terrific. Did Varshith want to add something remotely? And then we'll hear from Brian. Brian, if you can hear us, or Varshith is going first.
Sure, I kind of concur that. So I kind of concur with what Anthony said. And I think it's really important to kind of be involved with the community and try to understand what the problems are. So can you hear me?
Yes, yeah, thank you. Yeah, sorry, we're glitchy, but not bad. So then if we could hear from Brian also, his perspectives on things that he would have liked to have done, be able to do over.
I think my words of wisdom, really, we're all here for a reason, and it's a relatively altruistic reason to be here. We all have our own stories, so really just get out and talk to not just your teammates. Spend a good amount of time today really getting to know them before you even dive into all of your ideas. This is a team that you'll be working with all weekend, and hopefully, as the other teams had said, that it really doesn't end here. So make sure you get to know your teammates, and then lastly is don't think of this grandiose idea There's so many avenues to tackle these problems, either be increasing buprenorphine access, needle exchange programs, creating an app for education. There's so many different levers that we can pull. And if we start to think of this as a big, big problem, it gets very difficult, I think, to really come down with a concrete idea that most importantly is doable. So whatever you end up doing this weekend, make sure that it's kind of in the scope of bringing it somewhere. This is, an idea kind of hackathon, but at the end of the day, we do want to actually progress the needle to help alleviate all the pain and suffering that has happened during this opioid crisis.
That's really great. I think I'm just curious if the groups have perspectives to share on how do you know that the idea is not out there? It seems like, I don't know if you have many people have this experience, like, oh, I got a great idea, and then there's like 15 solutions out there. So how do you know either that you're onto something good, or that it somehow has some unique characteristic, or that it's set up to succeed where others have failed, that it has some value added?
You don't. No, seriously, you don't. And that's okay, because this is like a 2-day thing, right? And you're gonna, whatever you do, there'll be opportunities to keep vetting it. And I think you cannot research your way to a decision, and there's gonna be a temptation. Like, look, there's an enormous amount of literature, whatever you're interested in thinking about, there's an enormous amount of literature about it. There's tons of other people who've thought about it, right? So if you waste all of your hackathon time like trying to get caught up on your reading, then you are not going to get to a design. And so my advice to you would be, make preliminary decisions early and then vet them with the subject matter experts and the hackathon mentors who are here, and be ready to throw them out and make new decisions, and to really manage your time with a cycle of brainstorming. This is what we've got so far. Hey, this is what we have so far. What do you think? Oh, that's an incredible amount of new information that is changing our thinking. Great. Well, we're going to go away and then do that, as many cycles of that as you possibly can. That is the way that you'll get to something ultimately. Right? You've already heard it from the presentations. Like, most of the solutions, like, we know what to do, right? In broad strokes, we know what to do. Like, there's tons of evidence-based things about how harm reduction works and how it should be done and all these, right? So, and yet we're not doing them, right? And so it ends up coming down to the sort of state-specific, site-specific, context-specific reasons why that thing isn't being done. And so it's by connecting to the people here who can tell you about those details that you can do something that is meaningful to a real sort of local, real need, right? Like, Gordon's buttons are amazing for where they are, for the context. Like, they can't, like, the buttons couldn't even survive like moving to a different room in the same building, and they needed to design it differently for that new context. And that's going to be true in many places. So your job here is to come up with ideas and then we'll throw them against, yeah, and then see if you can come up with something that will really land for the context that you're in.
I love those perspectives. Thanks for sharing, Tim.
I mean, it really comes down to, so I think the question was like, how do you know you have a good idea? And I really do think it comes down to feasibility and just not over-promising in what you're building overall, right? So if you don't know about AI technology, don't say that you're trying to build something that's going to predict whether or not somebody's going to live on, opioids or something like that, or measuring. Stick within the realms of what you know, but do your research. If you have an idea, I'm sure somebody else has already thought about it. And if you go just a simple Google search, I'm sure you'll find a lot, just to either make yourself a little bit different or just see what they're doing and learn from them. So, do your research, and like everybody's been saying, listen for sure.
Great, thank you. And I don't know if Arsh or Brian can join us remotely for additional comments on thinking about what's already out there, what a unique addition or unique opportunity might look like.
So, yes, I think, so you can never be sure, but it's always good to have someone who has been in the community who has seen the problem at hand, right? So I think from a feasibility standpoint, as Anthony was mentioning, it's really important to have something maybe just like written on a whiteboard or on a map, and then kind of like go over it, right?
Sorry, we just lost you first. Okay. And Brian's also lost. Okay, so while we're waiting for them to reconnect, I guess I think most of you have day jobs / night jobs, and you're passionate, and passion carries us a good distance down the road. But on the 3rd month or the 11th month or the 18th month or the empty bank account, you know, at some point you need support. And so how are you sustaining now? How much do you have to map out when you bring on a full-time person or when you get a grant that can properly support you? So mainstay first. I'll ignore the laughter, okay?
What's the take home for prize 1 here? What is it?
$4.4 billion.
Yeah, okay. Oh, yeah, perfect.
Every team has a chance for $40,000 for an investment in furthering their idea.
So if that wasn't captured on the microphone, $400 per winning team member and up to $40,000 in support for each team that wins.
Perfect.
Sorry.
That'll
Yes.
help. That will help. 2 years ago, we won $5,000. And so we decided with that funds and then some additional very generous funds from the COBRE, I think that our take home for our project was $15,000. We decided to essentially do more research, do some subject matter expert interviews, to launch a website to further kind of our online presence, and to do an IRB study that really took into account the voice of the person with lived experience and also the people who care for people with lived experience. And we probably did as much in-kind work as we did paid work as a team over the last 18 months. Obviously, a lot of our ideas got changed and shifted around due to COVID. We were going to go to Philadelphia because they were potentially opening a site. We did not do that. We were going to go to Canada. No, we didn't go to Canada. But you know, like we didn't have a ton of money. And again, the idea that we had after talking even just very briefly with subject matter experts, it was such a large idea that we decided we really did need to go back and refine further. Because you can't build a building and hire staff and develop protocols and all of that with $15,000.
No, but I think it was, again, right, like hopefully it doesn't end at the hackathon. I mean, part of it too was the idea was ambitious. I think it then launched our team into, okay, what do we need to figure out to at least move towards that very large, ambitious idea? And so that was sort of the mapping that we did and a series of, you know, all this sort of activity that's followed since. I mean, we blew through the money quite quickly, but it's been, I mean, I think all of us sort of continue to engage in the work and sort of keep our team alive and the idea alive, because we're passionate about it. We think it's a good one. We think there's a lot of need around it, and we enjoy hanging out with each other and engaging with all the people that we've been able to engage with. So, you know, in addition to the idea, it's brought, I think, a bunch of other wonderful connections and relationships. I think that's super cheesy, but I mean that, I think, right, there's, yes, the funding and the money is important, and then all sort of the sort of soft stuff around it is super important too.
And while our idea has remained somewhat conceptual, we were waiting for this legislation, right? And so timing is incredible. Josh Miller is incredible. And so when something finally became possible, we had this treasure trove of information that we could then offer other groups that are doing this very powerful work. And at this point, that is voluntary. That's Wednesday evenings. But it's still absolutely worth it to get this larger idea pushed forward a little bit further.
Yeah, those collaborative relationships are so essential, and the fact that you had done so much pre-work, it aligns you up well to have a meaningful conversation with the stakeholders such as our representatives. So, Anthony, what are your thoughts about sustaining the effort, supporting the effort?
Yeah, so sustaining and supporting the effort, it's well, having a very good partner. So obviously, thank you to Varshit for just, obviously being a friend of mine and just going through this together. It's very, we're both technical guys. So us not always being in, the medical scene all the time, we have to constantly learn together. And it's a lot easier when you're doing it with somebody who's also equally as passionate. So, doing it with somebody, is pretty good. In terms of the funding and stuff like that, we're the tech guys, so we didn't have to worry about like the coding. We, money for us is obviously a thing because we want to use it as like a success measurement. And obviously you need money to run software. But really what we're more looking to see is, okay, where we find more passion and support in is, okay, well, what is this system going to do for people and how can we measure that? So, kind of figuring that stuff out is what's been keeping us going, and trying to see that impact at the end of the day is what's really, keeping us driving. I don't know if Flush has anything to add to that.
So I think that was a great
Yeah, I think,
enunciation.
as Anthony put it, I think it's been a really good learning experience. And I think that's really important to kind of be strategic in how you want to sustain your product, right? So I think having a partner, making sure that, asking questions, like if you didn't understand something, which is happening once you speak with your stakeholders like Victor, right? So I think it's important to have that back and forth, and having a partner always helps. And also since having the technical background also, I guess, provided a little bit of an edge. But at the same time, I think also going back to right, I think it's really important to just get something out there which is minimally viable, so that you can actually get as much feedback as possible. And I think that's the key measurement, to get feedback as quickly as possible so that you can actually use that feedback, reiterate, and then be strategic in terms of leveraging what you have to apply for grants and funds. I think that's the way to go in terms of sustaining the product.
I'd like you introduce the minimal viable product concept. I hear strongly in Anthony, the social entrepreneur driven by the passion and the impact that you're looking to have. I had the good fortune of going through an accelerator program down the street at the Social Enterprise Greenhouse. There are several accelerators like that, where you can get pro bono support from people who have the business chops, or who have the tech chops, or know the regulatory framework, or say, you really aren't going to build that medical device, are you? So they provide dope slaps for free as well. So, but and just mapping out, supporting your efforts, the support of the COBRE is wonderful. Grants are free, right? If you're lucky enough to land a grant, it's free money. It's not payback money or loan money. But as you try to promote your idea, there might be opportunities for small business impacts, other grants or payback type situations. So I think Brian, if he's connected, owes us 2 answers now. Just about how he knew he had a viable idea, and then how he and his team have been trying to support it and propagate it. So we'll wait for Brian to patch in here. Brian, can you hear?
Hey, sorry about that. So how do you know you had a viable idea? I think at the beginning of the day, you don't necessarily know you have a viable idea, but you decide that you're passionate enough about your idea that you're willing to make it viable. I think that's probably one of the most important thing, because if you want to make this viable long term, it's going to have to be something you devote some of your time to. Definitely, you know, a lot of resources. If it's money, if it's capital, you have to go out and get grants, and writing grants takes a lot of time and not always necessarily the most fun thing to do. But to really understand that you think your product is good and it's something you're willing to and wanting to work on, I think is what makes you know your idea is viable.
That's great. I guess, and then do you have any other ideas about sustainability, or at a point at which you need to build a team with, you know, people who don't have a daytime job?
So any other ideas for sustainability? You know, I think keeping in constant communication with your team is very important. There, you know, this is not necessarily everyone's full-time job, not necessarily making this a business. For our case, you know, we can as a completely free application. So making sure that you like the people you're working with. Again, you know, you all buy into a vision of what you're trying to do here. And then, you know, keep making incremental progress. You know, don't let it, you know, sit stale for too long. Always, you know, receiving feedback, you know, meeting with your team, iterating over things so it doesn't get stale on you, I think makes products viable.
That's great. So how many minutes do we have left, Dr. Green? Okay. Well, I hope everybody's found this informative. I've learned a lot listening to our panelists. I think they've shown great tenacity and innovation and great teamsmanship, and I'd hope the same for everybody else participating. Thanks for joining us.
That means my time. I'm Jody Rich, PI of the COBRE, and just so proud of everybody here and everybody online who's here. You know, we did this hackathon 2 years ago, and it's just great to hear people are still working on it and going ahead. And it's just wonderful. For that mainstay issue, I just want to, well, I do want to highlight that, you know, that we are the first state to approve thanks to the good senator and many others. And I think one of probably the most important thing we can do is get this across the finish line. And all we need to do is have one person come in to one facility and use a drug, or say they use the drug and leave, and that will break the glass, because all of a sudden everybody will realize, you know what, that's a big nothing. Nobody has to go crazy about it. It's not going to destroy the world. The sky's not going to fall. And so I just want to put a plug for getting as many people ready for this, because I don't think most Rhode Islanders even know that this legislation passed. So we have a very narrow time, because we are about to get an onslaught of heavy media attention. And it's going to, you know, people are going to be, all the opposition is going to come out. And if people have heard about it beforehand and have thought, oh, well, here's what's going to happen, and this is the reasons to do it, then they're going to be less likely to say, oh, well, less vulnerable to the negative messages. This was a great kickoff. And I've been working on this issue of overdose for many years. And the more I learn, the more I understand, the more I hear, and the more I see, the more complex I realize it is. And someone said once that for every complex problem, there is a single, simple, easy, and completely ineffective solution. Which really means we need a lot of solutions. We need a lot of hacks. We need buttons in certain rooms, and we need other things in other rooms. Tracy kicked it off that we have this epidemic within a pandemic. If we didn't have the pandemic, this would be by far the worst public health epidemic crisis in 100 years. And it's been overshadowed by the pandemic. So it's still there. It's getting worse. And then Brandon did a really wonderful description about how fear is really driving a lot of the craziness around this, and we really have to turn that around and get into hope. And then Kim did such a wonderful talk and really laid out a lot of things. And then she showed those 2 slides. Someone told me once, if you have a slide, you should have no more than 3 points on there. But she had the complete slide all completely written down. And then she had a second one all completely written down, completely full of ideas. And she went through every single one of them about the things that keep her up at night. And then I thought, well, gee, maybe she needs some drugs. But then I thought, well, we shouldn't say that. And in fact, the way she ended by showing the people that are close to her and close to all of us who have died really, brings it back home full circle that this is not, this is not really a joking matter. This is something we really need to do the best we possibly can. But and then we heard these wonderful panels about these great hacks. So like these are hacks that can happen and will happen this weekend. So that's really all I have to say. Get out there and get hacking. Thank you.
Okay, I'm going to close it up and get some sleep because we will see you tomorrow morning. And if you want to use the app or the platform to continue to talk and meet one another, please do so. But we'll look forward to seeing you bright and early tomorrow morning. Thanks.